Have you or someone in your family has ever felt tired throughout the day despite of sleeping all night? और क्या रात को ज़ोर से स्नोरिंग या फिर सांस लेने में दिक्कत महसूस करना आम बात हो गई है? तो ये एक ऐसी कंडीशन है जो सिर्फ स्लीप प्रॉब्लम नहीं बल्कि ऑब्स्ट्रक्टिव स्लीप एपनिया है। ये एक ऐसी कंडीशन है जो आपकी ओवरऑल हेल्थ पे काफ़ी सीरियस इम्पैक्ट करती है। सो नमस्ते एंड वेलकम एवरीवन टू अनदर एपिसोड ऑफ बियॉन्ड द पिल where health meets conversation. I'm your host Dr. Chetna and today we will be talking on a topic जो हम अक्सर इग्नोर कर देते हैं, that is obstructive sleep apnea, a silent threat to your health. Joining us today is Dr. D. N. Lognathan. He is a consultant interventional pulmonologist and has his expertise in pulmonary, internal, critical care and sleep medicine. He is a gold medalist and alumnus of AIMS Hospital, New Delhi. Dr. Lognathan has vast experience in advanced pulmonological procedure and has numerous contributions to national guidelines and research publications. So, hello, doctor. Welcome to Beyond the Pill and especially taking out time for us and coming to our show. So, how are you feeling about it?
Yeah, I feel it feels immense pleasure to be here, and I thank you for inviting me for today's program.
So, in today's episode, we will be talking about a topic which actually affects millions of people, but then it usually goes undiagnosed. That is obstructive sleep apnea. So, please help us understand this in a better way. Tell our viewers that what exactly is OSA or obstructive sleep apnea.
Yeah, this obstructive sleep apnea comes under a group of diseases called sleep disorder breathing, which is largely undiagnosed, unrecognized. People across the globe does not think that this is a disease that can lead to so many problems, health issues like heart attack, arrhythmias, heart failure, stroke, uncontrolled hypertension, accidents, roadways accidents, and increased mortality, so on and so forth. So this is largely an unrecognized problem.
Yes.
What we see now is only the tip of iceberg.
Yes.
Below the tip, there is vast majority of patients with sleep disorder breathing who are going unrecognized for two important reasons, because there is no awareness in public
Correct.
about this particular
Correct.
problem, and also lack of awareness among the physicians
Correct.
who are directly involved in treating these patients of various manifestations of this particular disease. So these are the important issues that leads to unrecognized entity as far as obstructive sleep
That's
apnea
correct.
is
Yeah.
concerned.
Yeah.
For example, if you take diabetes mellitus, hypertension, heart attack, the public is well aware of what are the symptoms and where they should get immediate consult and how to go about it.
Correct.
But for example, if a patient with OSA who snores at their house for many years, many months, have excessive daytime sleepiness and other problems, they don't recognize this as a disease.
Yeah.
They think that this is a part of their obesity, for example,
Correct.
and they learn to live along with this for many years. So there needs to be a lot of awareness as far as this disease is concerned, to pick it up very early so that we avoid the devastating consequences of this particular disease. It's so common that if you it all the prevalence of this is OSA all depends on which population you are studying.
That's correct. Yeah.
For example, you study a population, a Western population, Indian population, those who have excessive symptoms of OSA, no symptoms of OSA, but sleep disorder breathing is diagnosed with the polysomnography, the prevalence varies.
Yes.
In the West, if you take the data is as high as 30 to 40%, and it increases as the age goes higher, if the weight increases, post-menopausal women, and so on. If you take the Indian studies, the prevalence also varies from the group you study upon. You see, patient who has snoring at night while sleeping, and they have symptoms of OSA like excessive daytime sleepiness. See, they are in a work, gets dozed off. They are in a meeting, gets dozed off. And they read newspapers, they get dozed off. They are seeing television, gets dozed off. So these are the few symptoms of OSA.
So can these be like
if you take this along with a positive sleep study, then the prevalence is something around 5%. OSA can also affect men women and children also. So it is a largely unrecognized disease all over the globe.
All right. So as you mentioned that the person dozes off in whichever activity the person is doing. So is it like the classical symptom of obstructive sleep apnea?
Yeah. So the symptoms of obstructive sleep apnea is like this. One is related to the system at which it affects. For example, if increased forgetfulness, lack of energy, excessive tiredness, and memory loss, psychiatric disturbances, all are some of the neurological manifestations of obstructive
Correct.
sleep apnea. If you take the pilots, drivers, and other high risk individuals who are related to driving, they present to the hospital with sudden accidents.
Yes.
If you go and evaluate them, the underlying cause could be an untreated, unrecognized obstructive sleep apnea because they met with an accident because sudden dose of they are crashing into the accidents. So other thing is the bed partner's complaints. Like
Yeah.
my bed partner has excessive snoring,
Snoring,
loud
yeah.
snoring. We could not sleep in the room. There are some of my patients attenders used to say, no, if he sleeps in the room, we go to the first floor, second floor, and the ground floor. We are away from the room so that the noise is so much that we could not sleep around. There are some of my patients who travel in an AC coach and train, because of their snoring, the travelers in the same coach, they complain about the
They
loud
get
snoring,
disturbed. Yeah.
especially if it's an
Yeah.
air conditioned the coach
Correct.
you are traveling. And the daytime sleepiness, excessive daytime sleepiness, non-refreshing sleep, excessive tiredness, and lack of energy to do any work, and feeling of not slept yesterday,
Not
the
feeling,
previous
yeah,
night,
not sleeping enough.
and insomnia. And the bed mother complaining like this. So, no, my bed mother is breathing suddenly stopped and immediately he is waking up. So sudden choking of breathing,
Hmm.
sudden witnessed apnea is what we call. So these are the few symptoms, the manifestations at which the OSA can give you
All
clue
right.
that this particular individual has OSA.
But
Sometimes we also see patients indirectly, we pick up patients with OSA when they come for other diseases. For example, diabetes mellitus, they're obese, heart failure, not responding to therapy, systemic hypertension, not responding to therapy, arrhythmias, nocturnal arrhythmias, pulmonary hypertension, the increased pressure between the heart and the lungs connecting vessel called pulmonary artery pressure is high of unknown reasons, and the erectile dysfunction in men, and so many
hmm,
ways it can
hmm, hmm.
it can present. So the manifestations, clinical features of OSA are varied.
Yeah,
It can affect each and every organ. So we need to have the heightened awareness
of this,
and
yeah.
early suspicion to pick up
Correct.
an OSA patient.
But I'll tell you what, now that you mentioned that the patient snores at night, so there is large population who is actually snoring, but then no one takes it seriously. But what is that one symptom or one warning sign that tells us ki now it's time to go to doctor?
Anybody, any bed partner or any family member is complaining this family member has snoring which is loud enough to disturb others, is a time that they should consult a doctor, because there is something called upper airway resistance syndrome.
Okay.
It is a pre-runner
Hmm.
of obstructive sleep apnea. So there are various stages of evolution of the sleep
Hmm.
disorder breathing. You snore and you do a sleep study. Sleep study is negative, but still you snore. They come under the category of UACS,
Okay.
and they progress when they develop symptoms of OSA, as we discussed previously. Then they travel into mild, moderate, severe category. When they have symptoms, we call them obstructive sleep apnea syndrome.
Okay.
So it is a spectrum of disease. The message that I want to give you is to all the public is, if somebody who has history of snoring which is loud enough to disturb others should seek a medical consultation.
Okay.
Especially, for example, you are hypertensive, you are on different kind of medications, for example, highest dose of 3 different classes, you have history of snoring, you must get doctor consultation to rule out obstructive sleep apnea in those individuals. The reason why that your blood pressure is not controlling in this situation is not the lack of effectiveness of the medication that what doctor gives you, is the lack of recognition of obstructive sleep apnea in these
Correct.
patients, and you're not getting treated for this.
Right.
Yeah.
So once the patient comes to you, how do you assess the patient?
Yeah. So whenever a patient comes with the OSA, the assessment is like this. Usually, whenever a patient gives history of snoring, daytime sleepiness, then it is very easy to suspect obstructive sleep apnea. So one is the patient presentation. Patient himself or herself comes with a history of snoring, and all those symptoms which we have narrated previously, they come with, then we assess this patient whether this patient has OSA or not. So these patients will undergo physical examination, relevant laboratory tests, and the sleep study later to prove and disprove the same. And other situations wherein we should suspect as a doctor, one should suspect OSA are whenever they have the neurological manifestations which we have described previously, like recurrent stroke, lack of energy, forgetfulness, memory loss, lack of concentration, and non-refreshing sleep, erectile dysfunction, pulmonary hypertension which was unexplained, and the road traffic accidents, and nocturnal arrhythmias. So these are the situations, and diabetes mellitus which are poorly controlled, hypertension, all these things. But the point that one should stress here upon is any obese individuals, especially when the body mass index is more than 30,
Yeah.
you should screen all these patients for obstructive sleep apnea so that you pick them very early and treat them accordingly.
Right.
Yeah.
So do you have any interesting examples?
Yeah, there are a few of my patients. I'll share with you some of our experiences, the history that we get from our patients. There are patients who lost their jobs due to obstructive sleep apnea syndrome. We had a patient on businessman used to do his business in two-wheeler. He rides the bike or whatever it is. He used to keep one of his friend behind the two-wheeler, just to wake him off, because he frequently dozes off, stops, he falls down from the bike. So he employs the other person to sit behind him to wake him up. Boss,
Yeah.
don't doze up, don't doze off like that. We have had patients, lost their bank jobs due to this obstructive sleep apnea syndrome. So we had a patient once, cashier, had snoring, excessive daytime sleepiness, and he used to doze off while reading newspapers, while talking to others in a meeting or waiting in a signal, road signals. He frequently dozes off. Actually, this gentleman was accused of handling the money from the bank, and he was pushed off his job of taking the money away from the bank and such kind of activities. When he was submitted to medical examination, we found that he has significant obstructive sleep apnea syndrome, and his sleep study was strongly positive. We started him on CPAP therapy, and all his symptoms have improved. Going back to his history, in the office, while he was sitting and distributing cash, unknowingly, he had distributed a lot of money not accounted for.
That's bad.
So these are the situations that you can have patients who can present to you
Yeah.
for medical evaluation.
Yeah.
One of my friends' father who had recurrent arrhythmias, recurrent heart attack, was evaluated further for the underlying cause for repetitive the arrhythmias. He was posted for the electrophysiological study, and that time I was doing my post graduation at All India Institute of Medical Sciences, New Delhi. We at that time I was posted at sleep lab. I was sitting in front of the sleep study and scoring sleep study of a patient. While scoring, he came to my room to see me, and suddenly when he was coming, then I was seeing one of the patient's sleep study wherein the electrocardiogram showed repeated ventricular premature complexes and on-stage ventricular tachycardia, which was ill-sustained, which was seen all through his night. He was telling to me that my father is getting posted for EPS next day, and you are seeing this EKG findings in this patient with sleep disorder. Breathing. Is there any connection? Yes, I told him that there was significant connections, and he told me that his father has the snoring, which is loud enough to disturb others, so nobody else in the house sleeps along with him in the same room, and he has excessive daytime sleepiness. Next day, we posted him for sleep study. We found very significant sleep apnea, severe OSA. His AHI was more than 100 with symptoms of obstructive sleep apnea. We started him CPAP, and his medications requirement for hypertension, his diabetic control, heart failure medications has significantly come down, and he did not undergo the electrophysiological study. So these are the situations that the patient can present to you. They can present to different department for different manifestations. The factor which predisposes to that particular disease one needs to think of, and OSA is such that they can present in different departments.
What I am understanding from this is that if not the patient, the family members or anyone with them needs to have this awareness about sleep apnea so that even the patient can get properly diagnosed with it.
Yeah.
And more than that, properly treated for it, right?
Yeah. So any patient who is obese
Obese, falls under the risk category.
is a most important risk factor.
So how many patients do you see in your daily routine with sleep apnea?
Yeah, no, all depends on, it varies from, if you start asking history of snoring, then around 5 to 10% in a day, which is a huge number. Which is a huge number.
Yeah.
And the prevalence of OSA varies from different patient population.
Okay.
If you take high risk individuals, like patients with recurrent stroke, resistant hypertension, uncontrolled heart failure, there is something called low atrial fibrillation, unexplained pulmonary hypertension. Then this high risk other individuals like the drivers, pilots, and train drivers, and so on. The prevalence is high.
Correct.
Prevalence is in general population without this comorbidities, the prevalence is low. So all depends on what population that you are seeing is the key to tell us what is the exact figure.
All right.
The point here I want to make today is, heightened awareness of this particular disease is so much important to pick this up very early.
That's correct. So is it like sleep apnea is seen more in men as compared to women?
Yes, it's common in men, but
Okay.
in post-menopausal women, due to change in hormonal milieu, it almost equals the men. It can also be seen in children.
Children, yeah.
We tend to say that obstructive sleep apnea is common in patients with obesity,
yeah,
but
majorly.
it can also occur in lean individuals also.
All right.
So there are factors which predisposes to OSA in a particular individual. One is the anatomical, another is the non-anatomical factors.
Okay.
For example, you have deviated septum, nasal septum. You have chronic rhinosinusitis. You have nasal polyp. You have tonsils which are enlarged. You have enlarged adenoid. And you have the maxilla which is retropulse.
correct,
You
yeah.
have mandible which is retropulse. And your BMI is more than 30. And you have neck circumference
Yes,
which is, for example, more than 43 centimeters in men, for example. And you have short neck. And you have the distance, what we call these mental to thyroid. Thyroid distance is very short. So these are the predisposing anatomical factors. But patients with OSA can have this upper airway which is normal, still they can have OSA, like what we call the pharyngeal dilator muscle dysfunction.
Correct.
And you can have this ventilator control instability over the breathing. So you can have central mechanism, you can have non-central mechanism. So depending on that, you have various types of obstructive sleep apneas. And patients with acromegaly, patients with hypothyroidism also
Can
more risk
sometimes
for
get this.
more risk for developing obstructive sleep apnea. There are certain congenital syndromes are also there.
Okay.
It can be ethnic predisposition, can be familial predisposition. Sometimes we see obstructive sleep apnea syndrome running in families.
Hereditary.
Father has,
Okay.
mother has, children has. So there is a genetic link towards. It also gets exacerbated somebody who takes sleeping pills.
Okay.
So because of lack of sleep. They take pill, and they take more dose, then upper airway collapse becomes more, then they more
Yes.
the repetitive collapse of the upper airway, so they develop the symptoms of OSA.
Okay.
And also patients who are alcoholic,
Yeah.
heavy smoker,
Yeah.
it also affects the upper pharyngeal airway
That's
muscles.
true.
Airway
Yeah.
muscles. It causes dysfunction. So the lumen, which has to be maintained in a patent, becomes collapsed at night, and the respiratory flow becomes complete cessation. There is, and you can develop an obstructive sleep apnea.
Right.
So there are various mechanisms in which that on somebody can develop an OSA. So the most
Okay.
important factor is a repetitive collapse of the upper
Okay.
airway is a
Okay.
key for development of obstructive sleep apnea. It
Okay.
can be obstructive, it can be central, or it can be, the sleep-related hyperventilation and hypoxia.
Correct.
So these are the various ways that one can have the presentation of sleep disorder breathing
Okay.
when you see all these patients in our hospital setting.
Right. But from this discussion, what I came to know is that because of some problems, some condition, sleep apnea is occurring. Is it possible that due to sleep apnea, sleep apnea has been associated with some comorbidities?
Yeah. So sleep apnea can be associated with other comorbidities, which we have discussed previously, related to nose, the recurrent rhinitis, sinusitis,
Okay.
nasal polyp, tonsillar enlargement,
Same.
adenoid
Okay.
enlargement, and
Understand.
other diseases which we have discussed, like diabetes, hypertension, heart
Okay.
failure, stroke, arrhythmias, all
Right.
these.
Now,
And what we have found is because of the snoring, the sound, that can get transmitted to our neck vessels. So what we have found is because of this transmission of the noise signals, we are seeing patients with OSA having increased the carotid intimal thickness. Once you start them therapy, for example with CPAP, this carotid intimal thickness in the neck vessel comes down.
okay.
So largely it produces tremendous amount of the endothelial dysfunction.
Okay.
There is significant systemic inflammation, and that leads to problem in every vascular
Correct.
territories.
All right. So now,
We also seeing as a pulmonologist, it can coexist with other pulmonary disease also. For example, the one of a study which was published in Lung India, the prevalence of obstructive sleep apnea in COPD patients are to the tune of 11%. 11%. So we have taken up patients with chronic obstructive pulmonary disease patient who have history of OSA with snoring and excessive daytime sleepiness, and those who have disproportionate pulmonary hypertension have persistent symptoms, not responded to the optimal medication of COPD. But once we started recognizing the unrecognized OSA in those patients by the way of sleep study, after proving sleep disorder breathing in them, once we started CPAP in these patients, they improved significantly.
right.
This we call overlap syndrome.
Okay.
COPD with OSA can get associated with asthma. One of the cause for the poorly controlled asthma is unrecognized, untreated obstructive sleep apnea syndrome. Can be associated with interstitial lung disease. It can be associated with get associated with any other lung disease, any other non-pulmonary disease also. So this is an additional unrecognized problem that should raise heightened awareness to pick up the early warning signs so that you start treating these patients.
Correct.
Not only at that particular point of time, you must keep these patients for long-term follow-up so that they don't relapse and they are on your advice till the end.
So you kept mentioning that the patient has been given CPAP. So CPAP is the best treatment option available for patients with sleep apnea, right?
Yeah. So once we diagnose obstructive sleep apnea, there are various treatment modalities which are available. One is medical therapy, another is surgical therapy. Before going to the treatment part, I should tell you how we assess a patient with sleep disorder breathing. There are questionnaires which are available for suspecting the high risk individuals. We call it as ESS score, Epworth Sleepiness Scale score.
Okay.
Another is Berlin score. They have a modification of that score called Modified Berlin score and Stop Bank questionnaire. These are the last questionnaires used by anesthesiologists by assessing during the preoperative assessment of patients with the suspected OSA. So for example, if there are various parameters in ESS, there are 8 parameters like daytime sleepiness assessment, like it will assess the patient sleepiness during various day-to-day activities, and if the score is more than 10, we presume that this patient is high risk for OSA. Likewise with other questionnaires. So, and also the other physical parameters we assess, like body mass index, the neck circumference, thyroidal distance, and the position of the mandible, maxilla, nose, and detailed assessment of the upper airway, including the nose, nasopharynx, and oral cavity.
All right.
Sometimes somebody who has large tongue can get predisposed to OSA, because while sleeping, the tongue gets tongue moves to the posterior aspect and there is an
it rolls back.
abstraction. Okay, so these are the physical assessments that we do. Apart from this, there are various other the tests to which are used for assessment of these patients, like evaluation of endocrine dysfunction, like hypothyroidism, acromegaly, and so on.
Okay.
There are various other imaging tests, like the CT scan, MRI scan, nasal endoscopy, and drug-induced sleep endoscopy, what we call DISE. So all these are the evaluation, the procedures that we do
assessment
before moving to a sleep study.
Okay.
So once we are sure that this particular individual has OSA, we categorize them as mild risk and high risk, moderate risk.
Okay.
Those who are high risk can undergo sleep studies.
Okay.
In our country, the problem is the lack of awareness.
Yeah.
Another is the availability of the laboratory support for the sleep studies.
Correct.
So there are various types of sleep studies available.
Yeah.
We call them as portable monitoring and in-house polysomnography. There are type 1 studies, type 2 studies, type 3 studies, and type 4 studies. There are very minimum, if you do a sleep study with minimum 7 channels in the sleep study, along with a trained technician, sleep technician, who is supervising this sleep study, we call it as type 1. And if the trained technician is not supervising, then it is called type 2 studies.
Okay.
And there are various the parameters we assess during sleep study, like we keep electrodes for assessment of the EEG signals. We assess electrooculogram.
Right.
We assess nasal airflow, oral airflow, the pulse oximeter, heart rate, thoracic movement, abdominal movement, and so many things are assessed during sleep studies. Depending on the reduction of the parameters, devices that you use in sleep study, this is being categorized between type 1 to type 4. The point I want to stress here is, if the patient is high risk of OSA, like BMI is 45, every night he snores, every night he snores, he have significant daytime sleepiness, has heart attack, and has other problems, these patients will be categorized under high risk. If the patient is not able to get the appointment for the type 1 studies, patient is having high risk of OSA but not having significant comorbidities,
Correct.
they will be submitted for they can be asked for portable monitoring sleep studies.
Okay.
Because the idea of doing this PM monitoring is, the below the type 2 studies are, to pick these patients early so that you give them treatment very early.
True.
The problem here are two important things. One is not being supervised by a trained technician.
Yeah.
One, and the assessment of the apnea hypopnea index can be varying, because the AHI is one of the parameters that we use for categorizing mild, moderate, and severe OSA. AHI is apnea hypopnea index per hour of sleep time. That is the measure which is being used. Less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. If somebody who has AHI more than 5 and they have symptoms of OSA, we call them as obstructive sleep apnea syndrome.
Okay.
For example, you have a patient, obesity is there, but no snoring, no daytime sleepiness, and no other symptoms of OSA as we have discussed previously. But their AHI is, for example, more than 15. Still they we call them as OSA and we give them treatment.
Okay.
So this is how we assess a patient. We do sleep studies in these patients.
Okay.
So after diagnosing sleep studies, after diagnosing the OSA, these patients will be assessed for the treatment.
Okay.
Treatment depends on medical treatment,
Yeah.
device treatment,
So,
and the surgical treatment.
Yeah.
You see, the drugs medical treatment is largely addresses the underlying comorbidities, for example, diabetes, hypertension, the heart failure, ischemic heart disease, and so on. We don't have large number of drugs. We don't have potent drugs for treatment of obstructive sleep apnea, except the treatment for the residual persistent daytime sleepiness with drugs like modafinil and so on. Somebody who have started on CPAP, still the patient has persistent daytime sleepiness, then you use all these drugs to maintain the wakefulness in daytime.
Okay.
But the coming to the treatment of the OSA, the most important treatment is continuous positive airway pressure, what we call CPAP machine.
Yeah.
There are various types on that. CPAP machine, pressure leak, CPAP to reduce the pressure at the start of the treatment, auto CPAP, and bilevel pressure, and so on. These are the different devices that we use during titration during a sleep study.
Okay.
So what does the CPAP does in this patient is, we have seen that in OSA, the upper airway repeatedly collapses. So the lumen like this becomes like this. So there is complete cessation of flow. The flow is reduced 10 seconds, then we call it as apnea.
Okay.
And if it is reduced by 30% and you have a desaturation below 3%, so desaturation to the tune of 3%, comparing the previous saturation, we call them as hypopneas.
Okay.
So what does this CPAP machine is to, it splints pneumatically the upper airways so that air goes freely into it.
Yeah.
So this CPAP titration is done during whole night study, during sleep studies, and you can do sleep study previous day and you can do the CPAP titration tonight.
Okay.
But there is the next day. Sometimes we can do the split night study, wherein if the AHI in the first 2 hours of sleep study, if it is more than 40, then one can resort to titration with the CPAP on the same day to prevent the time delay and to of diagnosing OSA, and to prevent the lot of waiting list for these patients later on. So CPAP is the sheet anchor
But
for treatment of OSA patients. Yeah.
But then this sleep study can be only carried out in hospital, or patient or any other family member can also be taught how to do it at home?
Yeah, so this is a very important question. So this brings up what is called PM, portable monitoring. The another is in-house monitoring, polysomnography, which is done at the hospital. Any patient who has high risk of OSA and who have significant comorbidities like uncontrolled heart failure, uncontrolled hypertension, underlying pulmonary hypertension, somebody who has chronic obstructive pulmonary disease which is very severe on oxygen, somebody who has recurrent arrhythmias, even though this patient can get sleep study at home, they should not be advised to undergo sleep study at home because these are high risk individuals having underlying severe significant comorbidities and high risk of this OSA. So these patients are ideally advised to undergo sleep study at hospital setting. Imagine a patient who have no high risk comorbidities like as we have mentioned previously, but high risk of having OSA with the scoring and other anthropometric measurements, they can be advised to do sleep study at home. At home, it can be a non-attended the sleep study. There are the fallacies about these studies, like the false measurement of the AHI. The idea of doing portable measurement, the portable monitoring is to prevent the long waiting list for sleep study, one, and number two, to start these patients on CPAP therapy as early as possible. For example, you have a patient with stroke, you have a patient in the third floor, fourth floor, no lift.
Yeah.
The patient attendants are saying they cannot bring the patient to hospital, and for whatever reason. And these are the other indications for doing sleep study at home also.
Yeah.
The other, for example, you have done a sleep study at home, portable monitoring, but the doctor thinks that this patient is
not
high risk of OSA, but portable monitoring is becoming negative after the sleep scoring. Then these patients should ideally undergo sleep study
at
at
hospital.
hospital
Okay.
to rule out the OSA in these groups.
All right.
So to answer the question, whether to do home sleep study or hospital sleep study depends on the risk stratification of these patients. One, two, underlying significant comorbidities. Three, for example, you have a patient with sleep disorder breathing with associated comorbidities like patient has restless leg syndrome, somebody who has low saturation during sleep, somebody who has seizures. So these are the patients that you should ideally submit them for a in-house sleep study, ideally attended by a very well trained sleep technician
Yeah.
to monitor what is happening at night. Because in given circumstances, we do video recording also during the sleep study. So the leg movements, what you call periodic leg movements, and so many other problems which occurs associated with OSA can also be picked up during in-house studies.
Okay. So is it possible that if the patient with sleep apnea goes untreated, can there be sudden deaths?
Yes. So there are patients of ours, there are patients who are dying suddenly during the waiting list of for sleep studies.
Right.
So one of the presentation of untreated, unrecognized severe OSA is sudden death.
Okay.
So for example, you imagine a situation wherein patient has BMI of 45,
Right.
has sudden emergency, surgical emergency. Previously, that patient had snoring, excessive daytime sleepiness. The patient, because of surgical emergency situation, undergoes surgery. These untreated, unrecognized OSA in that particular individual can have a huge consequences in the post-operative period.
Okay.
Post-operatively, they can have low saturation, varying heart rate, arrhythmias, sudden cardiac arrest also. So it can be fatal also.
Okay.
So unrecognized significant severe OSA can be fatal. It can lead to high mortality.
All right.
Yes, it can lead to death if it is not recognized at
So
appropriate time
sleep
and treated.
apnea is just not snoring, but it has a very huge impact on entire body, right?
Yes.
So just now we spoke about the medical management part of it. What about the non-medical management, that is lifestyle modifications, weight management or exercise? How impactful is that in improving or managing sleep apnea?
Yeah. This is the most important question. The treating sleep disorder breathing is not about using CPAP machine. It's not about using PAP machine alone. It should start with general measures like constant involvement in exercise is paramount important to reduce the weight.
Okay.
We have seen patients who are started on CPAP therapy, PAP therapy for OSA, for example, in severe OSA. If they continue to lose weight, then their response is very good during the follow-up. On the contrary, you have a severe OSA patient who has a BMI of 45, you have proven sleep disorder breathing OSA based sleep study, they continue to gain weight, then they don't respond to your CPAP therapy at all.
Okay.
So, strict dietary advice, low fat diet, and weight loss program is paramount important in these patients.
Okay.
We must advise them not to smoke
Yeah.
because smoking has direct relation with the muscle dysfunction of the pharynx, as we have discussed
Right.
previously. They should avoid alcohol
Alcohol.
intake.
Yeah.
They should avoid sleeping pills because if they take sleeping pills, it also collapses upper airway paradoxically, and you have more obstructive events. In fact, we when we pose patients who are on sleeping pills for sleep studies, We stop sleeping pills, for example, 2 to 4 weeks before submitting these patients for sleep study, because you falsely score certain events during sleep,
Right.
and it can falsely can have implications on the severity assessment in the sleep study. The other most important is avoiding driving is the most important written prescription that we give.
Okay.
We always advise all our untreated, newly diagnosed obstructive sleep apnea patients not to drive, not to drive, not to drive. I think this message is very important.
Correct.
Our patients used to say, there are patients who are not listened to our advice and met with an accident, and after that, you cannot do anything on their lifestyle later on. So avoiding driving is paramount important. Advising them for good sleep hygiene is very important.
Okay.
Good sleep hygiene is paramount important along with this. Addressing comorbidity is very important. For example, you have a patient with OSA. If they have severe hypothyroidism, if we treat, there is a possibility that OSA can significantly get resolved in that patient.
Okay.
Any obese individuals, especially those who have gained weight very recently excessively, should undergo extensive endocrinological evaluation to rule out underlying secondary causes.
Okay.
And also, patients who are taking steroids can also have the problems with muscle myopathy, and they can have problems with this. So, relevant advice to the underlying drug intake is very important.
Okay.
So, apart from this general measures, we should assess them for appropriate therapy. The most important therapy is PAP therapy, which we have discussed. For example, you have a patient with mild OSA, moderate OSA, symptoms are plus minus, still you want to treat them because of underlying other comorbidities, then you can use what is called as oral appliances. There are various oral appliances. There are mandibular advancement devices. There are genioglossus appliance devices. There are the other oral appliances which our dentist evaluates meticulously and advises to them to use. Studies have shown in those patients who are not willing to use CPAP machine and still they need to get treatment, starting on oral appliances in these individuals, especially when they are mild to moderate, it serves them very good purpose in terms of reducing their symptoms of OSA and also consequences of OSA in those individuals. The other important treatment is the surgical part.
Okay.
So before starting evaluation for surgical candidacy in that particular individual, we should assess the level of obstruction in these individuals. One most important thing that one should think is, once you submit these patients for surgery, you should not think that OSA is completely cured.
Correct.
You should keep them on CPAP. You should follow them up for complete resolution of the OSA in that particular individual. One can have more than one mechanism of OSA. So, treating surgically that obstruction significantly reduces the level of severity. But still, they can have residual OSA, so they should be put on CPAP therapy. There are various surgical methods: uvuloparatopharyngeal adenoid removal, tonsillar removal, and the genioglossus muscle surgeries, and the mandibular advancement surgeries, and so on and so forth. Other most important surgical aspect is bariatric surgery. There are various surgical modalities coming under bariatric surgery, like the gastric banding, the gastric bypass, and the biliopancreatic diversion, and so on. One should understand about the surgical modalities, bariatric surgeries as related to CPAP. The OSA is, these patients should be put on CPAP for adequate period before submitting these patients for surgery. They can reduce the appetite. They can reduce the weight by reducing the appetite and producing some sort of malabsorption. But still they can have residual apnea, and they should be put on CPAP and follow.
Thank you so much for joining us today and providing such a clarity on every aspect of sleep apnea. Thanks a lot.
Thank you. Thanks a lot for inviting me.
So we will be doing a short segment that is myth versus fact, and that is bursting myths about obstructive sleep apnea. So I'll be stating few questions. You have to answer whether it's a myth or a fact. All right. So let's start with it.
Yes.
First one is snoring always means you have OSA.
Fact, but any patient with snoring should undergo evaluation for OSA, but need not be always a snorer has OSA.
Okay. Next one is OSA can increase your risk of heart disease and stroke.
Fact.
All right. Next one, only overweight or obese people are at risk of developing OSA.
Myth, a lean individual can also have OSA.
Correct. Next one, children cannot develop OSA.
Myth, they can have an OSA. So we need to have highest suspicion if they have symptoms of OSA.
All right. Using CPAP machine is one of the best and most effective treatment for OSA.
Fact.
Okay. Next one, OSA doesn't require treatment unless it causes severe symptoms.
Myth. So we have to start treatment as early to prevent its catastrophic consequences.
Lifestyle changes like weight loss, avoiding alcohol before bed can improve OSA symptoms.
Fact is a paramount important.
Last question, OSA can go away on its own without any intervention.
Myth.
All right. Thank you so much for your time today. It
Thank you.
was
Thanks a lot.
great meeting you. If you find our videos informative, don't forget to subscribe our channel and follow our page on Instagram at Mankind Specialities for more such health discussions on various health topics. Until then, stay informed, stay healthy.